Patients presenting with testicular pain is a not uncommon occurrence. In the case of torsion, the window of opportunity is said to be about 6 hours. A linear or handheld probe should be used with a depth of 3 centimeters. Small organ setting and color flow are helpful. A side-by-side comparison, so-called spectacle view, can be very helpful. The other things that can be distinguished are epididymitis and hydrocele. Patients presenting with pharyngitis is common. In the case of an exudative pharyngitis, the diagnosis that comes to mind is either streptococcal disease or mononucleosis. However, in either case, the major problem is the possibility of obstruction from an abscess. The tonsil and the normal surroundings, the vascularity, can be distinguished on ultrasound using a submandibular view with a transducer placed under the angle of the mandible with the probe marker facing towards the patient's ear. Cellulitis is another common complaint. A linear or handheld probe is optimal, and there's a characteristic change in the soft tissue, superficial soft tissue, called cobblestoning. On the other hand, tenosynovitis will show the presence of fluid within the tendon sheath or around the tendon. Lymphedema, particularly as patients get older, is a common occurrence, and the combination of a suspected cellulitis is vexing, usually treated with antibiotics, just in case. But ultrasound is useful in this setting. Look for the characteristic changes of inflammatory edema, the so-called cobblestone, and distinguish that from lymphedema. The videos presented show short and long axis views from the site of suspected inflammation. In the short axis, the cobblestone appearance of inflammatory reaction is clearly visible. The lymphedema changes are apparently obliterated. In the long axis, there are marked changes suggestive of lymphedema. Consequently, both views are needed. Lymph nodes are examined with a linear or handheld probe, a depth usually deeper, 6 to 10 centimeters, with a musculoskeletal soft tissue setting. Lymph nodes have a cortex, a medulla, a capsule, and an artery and vein entering at the hilum. Patient is optimally placed supine with an interscapular pillow, head turned to the contralateral side, assuming that it's the neck that's being studied. The outer cortex is hypoechoic, while the medulla is hyperechoic due to lymphatic cords and sinuses. Heterogeneity, sharp borders, enlarged size, asymmetric cortex, central hypoechogenicity are all signs of pathology. Signs of inflammation or swelling, particularly in the hand, bring the suspicion of inflammatory disease, perhaps suspected rheumatoid. Hockey stick probe, linear or butterfly probe will work with a musculoskeletal soft tissue setting and a relatively superficial depth of 2 centimeters. Sufficient gel should be used to allow minimal transducer pressure and therefore prevent the obscuration of joint fluid or synovitis. Key findings are thickened synovium and joint edema. If a metacarpal phalangeal or an interphalangeal joint displays any of these findings clinically, it's a logical ultrasound starting point. Otherwise, the extensor aspect of the third metacarpal phalangeal joint is the recommended first examination point. The initial view is sagittal. The second area of interest begins at the dorsal radiocarpal joint in line with the third finger. A sagittal view here allows visualization of the radius, lunate, and capitate. Again, key searches are joint fluid, which moves proximally with pressure, synovitis, and hyperemia. Subcutaneous rod implants are problematic. The implant is not radiopaque, consequently it's not visible on X-ray or CT. Ultrasound or MRI is required. The Nexplanon contains barium sulfate and as a result is visible on X-ray, CT, ultrasound and MRI. The Jadel is visible on X-ray, CT, ultrasound and MRI. Note that ultrasound scan is an optimal technique for visualization of the above, for removal, if the rod is not palpable. Linear transducer or butterfly will work with a high frequency and a depth of 2 centimeters or less. Transverse application begins over the expected rod position if palpable. If impalpable, but an implantation scar is visible, that site will take precedence. Key features with Implamon and Nexplanon include the small echogenic white dot of the implant and the acoustic shadow below the dot. Determination of IUD presence is significantly complicated by our decision, for reasonable grounds, not to use intracavitary probes. In a number of cases, the results will be equivocal. Transducers to be used can be curvilinear, sector, or handheld, and the views sagittal or transverse. The acoustic window is a bladder containing urine, not distended, but containing significant urine. However, the consequent pass-through artifact effect from the fluid may obscure detail unless appropriate selective reduction in brightness is made. The butterfly interest group suggests an OBGYN-1 preset, a full bladder, long steady pressure to move overlying bowel out of the way. Copper IUDs are easy to spot, but levonorgestrel IUDs are fairly isoechoic. Look for the main body, not the little wings, which are harder to see. Sometimes the acoustic shadow behind the IUD helps to reveal it. A major problem is that bile is capable of causing shadows of variable echogenicity and will cause confusion if not recognized.